Good evening and welcome to this special NPS MedicineWise seminar on difficult to treat and severe asthma. Today we're going to cover many of the issues of this common problem in primary care and many of the problems that we commonly follow. Management of asthma in adults remains difficult despite the excellent treatment that we have. Tonight we're going to be trying to cover the issues that I've just put up on the slide, management of asthma in adults, standardisation of asthma definitions and guidelines, and advances in the use of the targeted biologic therapies, and how multidisciplinary care can really improve health outcomes for our patients. We're grateful you've joined us today. We are focusing on adults today, and we won't be addressing children at all because that's not our brief. So I'm John Fardy, I'm a GP down the south coast of New South Wales, and asthma is one of the more common chronic health problems that we see in general practice primary care. Despite the fact that most patients do quite well and we've got excellent treatments, there are a group of patients who really do struggle. The management of these patients with difficult to treat and severe asthma is not only challenging for us, the clinician, it also does impose substantial burden on them and their lives. Today, I've got a panel of multidisciplinary experts to discuss the challenges and how we can move towards addressing those issues. So, the first person I'm going to introduce is Professor Helen Riddell. She's a respiratory physician, research leader at the Woolcock Institute, chair of the Science Committee of the Global Initiative Against Asthma. Helen, why do we have to do something to improve the care of people with severe and difficult to treat asthma?
Thanks, John. So the main reason is actually those burdens that you were talking about, the burden of symptoms, the burden of exacerbations or attacks. Also because there are many things that we can do in primary care to improve the quality of life and outcomes for those patients. And the other main reason why we're interested in this is because there are some new medications that are available for patients who don't respond to those normal basic principles of asthma management.
The next panellist is Dr. Juliet Foster, who's a research psychologist with a special interest in the disease beliefs, treatment attitudes and lived experience of people with respiratory disease. Juliet, how does understanding the patient's perspective influence what happens?
It's really so, thanks John, it's really so important to consider the patient's perspective. If we have a better understanding of the patient's knowledge, their concerns and their treatment goals, we have a better chance of giving medical advice that's really relevant to the patient. When it comes to difficult to treat or severe asthma, which is undiagnosed, actually in order to refer these patients, we need to know what's going on more in their home life and the barriers that are preventing them from either taking the treatment that's been prescribed, or perhaps they're having frequent or debilitating symptoms that we don't know about. That's why it's really important to understand the patient's perspective.
Leslie Vining is a clinical nurse specialist and asthma coordinator, Wollongong Hospital and the Illawarra region on the south coast, where I come from. She also works with Asthma Australia in providing clinical support to practice nurses. Leslie, what makes nurses such an important part in the management of these patients?
Well, I like to think of nurses as the glue and in the system, and I think it's really important that our communication skills are really good so that we can liaise between the patient and, especially with severe patients, there are many other respiratory physicians and maybe ENT people as well. So we're the go-to person sometimes, I like to think of, but also good nurses have a holistic approach to their patients, and that makes a big difference to them because they can see that there's a care, and when they're having such a severe issue with their asthma, it really does mean a lot to them to know that there are people that care for them.
So the poll question we're asking of you is, what proportion of your patients with asthma would you estimate as being difficult to treat? Is it going to be about 1% of your patients, 5%, 15%, or about 30% of your patients? I'm now going to move on to a few patient scenarios. Who are the people we're talking about? So these would be people who would fulfil the criteria that we're talking about. Someone who's on high-dose combination therapy and poor control in spite of that. people who are on high-dose combo therapy but needing lots of rescue oral steroids, 2 is the conventional number, and patients who are on maintenance oral steroids for their asthma and they haven't had any recent consultant review. So they're the people we're going to be talking about. Helen, what's the difference between difficult to treat asthma and severe asthma?
Yeah, so these are somewhat technical terms, but they do have specific meanings at present in international guidelines around severe asthma. So severe asthma is defined as a combination of 3 things. So can we have the slide up for that, please? So it's asthma that is uncontrolled despite maximal inhaled therapy being taken regularly and despite treatable factors having been addressed. So we'll go through those in a moment, but difficult to treat asthma is a much broader category of patients. This is patients who have asthma that is uncontrolled despite you having prescribed maximal inhaled therapy. And so you understand there can be quite a difference between being prescribed maximal inhaled therapy and actually taking it, or whether you have other factors contributing. So let's go through those one at a time. Let's have the next slide, thank you. So firstly, asthma that remains uncontrolled. So uncontrolled asthma can mean any one of these several things. So poor symptom control, symptoms several days a week, waking at night due to asthma, for example, limitation of activity due to asthma, frequent severe exacerbations or flare-ups or attacks, so 2 or more a year certainly. Having a serious exacerbation, for example, requiring hospitalisation or an intensive care stay. Patients who have persistent airflow limitation, or there is another group, a smaller group of patients who have well-controlled asthma, but that worsens when their corticosteroid treatment is reduced. So that's uncontrolled asthma. The second criterion is asthma that is uncontrolled despite maximal inhaled therapy being taken regularly. So by maximal inhaled therapy, we mean high-dose inhaled corticosteroids and a long-acting beta agonist. So for example, Seretide at more than 250/50 twice a day, or Symbicort more than 400/12 twice a day. So these are actually, in Australian standards, fairly modest doses in that a lot of patients are getting more than that. And then the third criterion is really important one, despite treatable factors having been addressed. So despite the patient actually taking inhaled therapy regularly, they may have these other treatable factors. So the most important of these are adherence with treatment, inhaler technique, avoiding triggers, and then comorbidities and modifiable risk factors that may contribute to either their symptoms or their risk of having flare-ups need to be identified and managed. So that's a pretty complicated definition of severe asthma. It's been constructed in that way because conventional asthma therapy with combination inhalers particularly is very, very effective when it's taken correctly and regularly. And the severe asthma population is the people in whom their asthma is relatively refractory to this conventional therapy.
So we've got an answer to our poll. We might put up that picture now if we can of the poll results. And that shows that about half the audience think that 1 in 20 of their asthma patients are difficult to treat. So 5% was voted for by 46%. The lucky people out there said only 17% of their 17% of people said that only 1% of their patients were difficult to treat, and about a third said 15% of their patients were difficult to treat. So they're quite substantial numbers of patients who are presenting us with problems in terms of managing their asthma. Leslie, how do we identify who are the difficult to treat people?
Well, if you've got patients that are coming into the practice, for example, that have been to hospital or they've been to emergency, and in some cases some are coming more often than once in a year. We look at each year at a time. if you know that that person is coming and having a lot of unscheduled GP visits because of their asthma being out of control, they're the sort of patients that you're going to start looking at what's really going on here. Is it inhaler technique, lack of preventer? Is it poor adherence in general to any of their medications? Perhaps asking them how often they would use a Ventolin puffer in a month, because that's a bit of a highlight to poor symptom control. And I think that would be a good way to identify difficult to treat, because you can see it's either the patient disease or their management of themselves with that disease.
And another thing that I think is possible, but whether anyone has got the energy to do it, is to actually use the computers that we've got on our desks, which is to look at who is on these higher doses of therapy, even though they aren't coming to see us. They might be going to hospital and we might not know about it, or they might be struggling on with lots of symptoms, which is something that Juliet will address in a little while, and we don't know. So you can actually do data extraction from the computer systems, and with the prescribing software that we've got, we love the prescribing software, so we can actually interrogate backwards about who are these people, but that does need some degree of proactivity in the practice. So, Helen, if they get admitted to hospital, it's pretty clear that their asthma's out of control. Are there any other ways that at your end of the system, you know, at the hospital end, the consultant respiratory physician end, if they aren't referred to you, how do you find them?
Well, if they're not referred, it's hard to find them. But so one way is to spread the word, I guess, whenever we have the opportunity to communicate back to GPs in a letter to explain why this particular patient had difficult to treat or severe asthma, and how to recognise this in other patients. So I try to use letters to communicate important information that might be useful for other patients as well. You
mentioned earlier, before we came onto the panel here, that the percentage is known of people with this disease from large studies, and it comes in at around about 17%, will you say?
With difficult to treat asthma, yes, if we can put up the next slide, please. So it's actually quite hard to find data about severe asthma, because although we often have a record of dispensing data, so we know what prescriptions have left the pharmacy, we don't necessarily know if they're taken. But this figure I've made from a nice study that was done in the Netherlands, where they have very, very good pharmacy records. And what they found from a population study was that about a quarter of patients, so 24%, were prescribed high-dose combination therapy. About 17% of the asthma population had uncontrolled asthma despite being prescribed that high-intensity therapy. But it was actually only 3.7% of the whole asthma population that would have at that time qualified as severe asthma by the fact that when their inhaler technique and adherence were checked, they were actually taking it regularly and correctly. So this severe asthma population is actually a very small proportion of the general asthma population. The patients with difficult to treat asthma who have fixable problems is actually much higher, and that's where primary care is really important in terms of identifying and managing them.
And we're going to address some strategies around identifying and managing those people later on in the program. So let's now move on to how important is it and how do we go about getting an accurate diagnosis of this disease? Because the reality of general practice, most of the people we see have got 2 or 3 things on the boil at one time. Everyone's time pressured, no matter where you're working at the moment. How do we go about getting this diagnosis right?
The best time to confirm the diagnosis of asthma is absolutely when the patient first presents, before they get put onto a preventer therapy. Because once they're on a preventer therapy, it's actually much harder to confirm the diagnosis. So the first thing is the typical pattern of asthma symptoms. So the symptoms of asthma are not specific for asthma. Wheeze, shortness of breath, cough, they can occur with many other conditions. But there are typical patterns in terms of the variability of those symptoms. the triggers for those symptoms, laughter, for example, viral infections, exercise. So there are some patterns that are recognisable as likely to be asthma, but it is really important to get objective confirmation with spirometry. And our guidelines have a series of fairly efficient tests that can be used to confirm variable airflow limitation in a patient who has typical symptoms. Now that sounds easy, but spirometry in primary care, I'm well aware, is challenging. And so it's good if you can identify a respiratory function laboratory or another practitioner who can actually do spirometry, or spirometry is sometimes offered in pharmacies or with nurse-led clinics. So as much as possible, try and document the diagnosis at the time of first presentation.
The fact is that it should be done. Who does it? As long as it's done well and it's done is what's important. So in any local area, if you can find out where you can get high-quality spirometry, anyone who you think might have asthma or any other respiratory disease for that matter should have a high-quality spirometry done. And I'm sure we're going out to places where they don't have access to respiratory labs, but many, many people do. So find out what you've got access to and use that.
And I would just add, if you're not sure about the diagnosis, then that's absolutely a good indication for referral to get the diagnosis confirmed, not just because you want to have confirmation that they do have asthma, but because if this is not asthma, you might be missing some other condition that needs very specific treatment.
Yep. So you've mentioned that there are other diagnoses for the symptoms that people present with, but there's also comorbidity, multimorbidity, concurrent diseases. Do you want to talk about what are the other things that can influence people's control of their asthma?
Sure. So comorbidities are important because they may be actually causing the symptoms that the patient is presenting with, or they may complicate treatment. So the most common ones that may affect symptom control or their risk of needing to go to hospital or urgent doctor visits or complicate their management, obesity is an extremely important problem. Today, the figure of 60% of Australians, so it's going to be very common. Gastroesophageal reflux disease, if it's symptomatic, can cause symptoms of nighttime cough, for example. Obstructive sleep apnea, particularly again in the obese group. Rhinitis, sinusitis, nasal polyps can cause cough, difficulty sleeping. Upper airway dysfunction or vocal cord dysfunction is a particularly common one in that it can beautifully mimic asthma, even to the point of patients ending up in intensive care intubated. So it's really important to try and identify the symptoms that make it more likely. For example, triggers of strong smells or speaking on the telephone or symptoms that are primarily on breathing in rather than breathing out, those things may make it more likely. COPD, so asthma in a smoker is much more severe generally than in a non-smoker, but some patients can have both asthma and COPD. And then there are short-term conditions, respiratory infections, prolonged post-viral cough that may confuse the issue. And a really important one here, it's not at the end because it's not a problem, but because it is so common, and that is depression and anxiety and panic disorders, which can either coexist with or mimic the symptoms of asthma.
So we've done the relatively easy thing of prescribing. Now the two big issues are, how do we know that they're taking their device properly, so they're getting the medication that we've prescribed for them? So I'm going to give that to Leslie to start with. How can we quickly assess that a person is able to use their inhaler device properly?
Okay, the best thing is for the patient to either bring their own inhalers in, or I suggest to all the practice nurses that I deal with to have a little box full of placebos so that they can actually show you, the clinician, the expert, on how to use that inhaler correctly. And I always say to my patients, please show me how you would use that and I will correct you if I need to. And that goes down fairly well. And that's the best way, but you can't just do it once. Every time they come in, it's really important to reassess their inhaler technique to ensure that they're doing it correctly, because we want it to go into their lungs. And if it's not done correctly, it can cause issues in the mouth and throat, as you're probably aware. So inhaler technique is very important. And then, of course, we'll be talking about adherence a bit further on.
Yep. The other resource we can often use is our pharmacist colleagues. That I use a little space on the end of the electronic prescriptions to write notes to the pharmacist. Please review inhaler technique. I'm not job shifting sideways, but it's just using the team that we've got around us to use it, because this is a real common problem, isn't it?
Absolutely. So the studies that we've done in community pharmacies and in other settings have shown that around 80% of people have incorrect inhaler technique. So essentially, you assume that inhaler technique is incorrect unless you've actually seen them taking it correctly. And I'd just like to reinforce Leslie's statement that you need to actually check it as often as possible. So, you know, pharmacists are in a good position to do this because they are that's the person who sees the patient the last time before they go home and start taking it.
Okay, so we've done the two easiest things, which is we've prescribed the correct medicine in the correct dose. We've got them using their device properly. Juliet, okay, how are we going to encourage people to actually take the medication as prescribed?
Yeah, and it's often, it's sort of bamboozling when, you know, you prescribe a treatment to a patient and they don't do what you ask them to do, even when it's clearly in their best interest. But I think it's really important to think of adherence actually as a rational or a reasoned decision-making process. You know, a patient's prescribed a treatment and then based on their own knowledge about it, their concerns about it, also their health goals and their lifestyle, that will lead them to the decision they make about a treatment. So say with a preventer treatment, they may perceive that as ineffective because they can't feel anything. One patient might say, well, I know how this works and, you know, I trust my doctor, so I'm going to take it. But you might have another patient who feels that this preventer is ineffective and they don't know how it works and they feel that any side effects they might have, however minimal, outweigh the benefits that they might achieve. So you can see how for each individual, their reasons for taking or not taking are quite unique. And really, that's the reason we need to get behind what's going on at home with our patients, if we possibly can. And we live in a very time-poor environment, but it's helpful if we can get to that stage in order to understand what's driving treatment taking. I mean, surprisingly, in severe asthma, there's a little bit of research, isn't enough yet, but adherence to preventers in severe asthma looks to be around 50%. So that's lower than most people might expect, although in the general community it's more like 30% actually in population samples. So what might be really helpful would be to look at some examples of how to discuss adherence with patients, because I imagine that's always a challenge in a sort of, when you have a quite short opportunity of time to do it.
And we often know that, oh, sorry, I've gone one too many. We often know that there's a little bit of negotiation between the patient and the doctor. I'm quite happy to say to you, you are taking your inhalers, aren't you? And you say yes, because it suits both of us to get out of there. But we know, amongst other things, that's not the way to proceed. So tell us some less good ways and then some better ways.
Well, let's put it like this. It's completely understandable in a short period of time to want to ask quite a closed question like, have you been taking your inhalers? But we all know the answer to a closed question is a yes or no answer. And you're going to get yes. That's what you're going to get. You can see actually on this slide different techniques that could be used, I guess, when you don't have a lot of time, basically asking a quick closed question, following that up with, I don't know, some assumptions about maybe why this person's asthma isn't going so well, and then attempting to increase the patient's knowledge and giving them medical advice. And that's all fine, but the trouble is you haven't been able to establish any information about the patient's background before giving that advice, which means it's going to be less relevant and less taken on by the patient. If we look at the second slide, you can see that the advice giving is there, but it's further down in the process. So you start off by asking the patient to ask you how they're going with the inhalers, ask them what they're concerned about, which is more about active listening and open questions, and also finding out the goals the patient has for their treatment. You can well imagine that Okay, not much time. The amount of words between these two slides isn't dramatically different, by the way. A little bit more listening time required. But then by the time you're giving advice, you contextualize it. I'm impressed you've given the preventer a try. That might not be many days a week, by the way. How would you feel about taking it twice a day to reduce your need for the blue reliever, which makes you shaky, and to improve your asthma so you can play with your son? It's contextualized. The patient's going to remember and connect those things. And then this bit of motivation at the end and a bit of encouragement. You know, why don't you give it a try and we'll see how it goes? The actual, I guess the feel of that discussion is quite different and can be really effective for you ongoing to understand how the patient sees their treatment and the type of barriers they have. Yeah.
Before we came on screen, you said something which really resonated with me, which was to ask a patient, you've sort of turned it around on its head a little bit, what have you had to change in your daily life to fit in with your asthma?
Yeah.
We want to sort out their asthma so their lives are better. They're actually inverting it and changing their lives to fit in with their asthma. So do you want to talk a little bit about that?
Yeah, I mean, a question like that is so helpful because if you have had asthma for a very long time, you've started to habituate to symptoms, maybe a little bit of denial going on because you want to get on with your daily life, your work commitments, your parenting. When somebody asks you how it gets in the way, you might tell yourself things as well as your doctor about how your asthma is limiting you. And that's so important for identifying people who may have poorly controlled asthma, perhaps severe asthma, perhaps difficult to treat asthma. That's why a question like that can really help both parties, actually.
Yeah.
Yeah.
And there's an emotional burden.
Yes.
For severe asthma, if you've had an ICU admission because of your asthma, you don't come out of that unscathed.
No, absolutely. And Helen and I actually worked on a study where we interviewed 25 patients with severe asthma around Australia. And actually, some of the results were kind of very revealing and in some way a little bit shocking. I've got a quick quote to read out from one patient which really encapsulates what's going on. This is from Rhonda. She's 54, female. She said, I've lost in every facet of my life, you know, my earning capacity, my self-esteem, my sense of achievement, my relationships, you name it, it's been there. And my asthma's been this severe all my life. That really tells you the breadth of the burden on an individual patient. It also highlights why there would be comorbidities around, say, depression, say, anxiety. When you have a condition that's affecting the course of your life, we found in interviews that people's careers had sometimes to be changed or they even had to leave the workplace, stop working because their asthma was so severe. And I'm sure you'll have seen this, all of you yourself. But the emotional burden on patients and also on family members. If you have a severe, or we know that patients with severe asthma have more frequent exacerbations, and you have a child in the house who's also witnessing this, and also a partner who's supporting you through this, this can have impacts on them psychologically as well. I don't know how much time we have, but in terms of limits on people's lives, some patients have symptoms every single day. You know, they can't walk uphill. They may not be able to do even basic household chores. Right through to people who say, my social life is limited and my friends might drop me because I keep getting invited to parties and I don't show up. This can have really significant effects on people's identity, right through to already mentioned career, but a sense of loneliness and being misunderstood. For example, partners, poor partners, they have to go through this with the patient too. So they can become a little bit of understandable fatigue where the partner starts to question, is it really that bad? And I think this will come up as we proceed through the webinar, that the community understanding of severe asthma and difficult to treat asthma isn't really there. Asthma is often seen as something fixable with a blue puffer, actually. And it leaves people with severe asthma with no one having a true understanding. And Helen talks a lot about this often, that there isn't that understanding. And it does mean that, that there's a stigma and also an isolation, even outside of the general asthma community. Severe asthma people feel quite different to everybody else and quite misunderstood. Yeah.
So, apart from the big issues of the right medication in the right dose with the right device, taken well, taken regularly, are there any other things that we can offer to these patients? I'm going to move on in a moment to the biologics, which have changed asthma management for the very severe patient, but has anyone else got any little tricks? What I'm hearing from Juliet is just hear how it's affecting them.
Yeah.
And yes, we are busy, but the right question at the right time might give you an insight and encourage them to come back, because regular review of asthma is encouraged but doesn't happen. But if people think it's going to be of value to them, they'll probably make the effort to come back. So any other little hints for us?
In asthma in general, or more in severe asthma?
Well, in difficult to treat and severe, but...
Yeah, I mean, I don't know. Leslie, did you want to say something?
I'm enjoying listening to you.
No, I think that, this more general, there isn't a lot of time in a general practice consultation. What I always say when I'm training communication skills, especially with GPs, really understand how difficult it must be. But over the long term, overseeing patients over many years, there are opportunities to have discussions. I think one of the really important things to be able to ask in an appointment with a patient is, tell me what this inhaler does for your asthma. It's such a simple question, but then you might find out that they don't know which is the reliever and which is the preventer. And a lot of people will stop taking their treatment because it doesn't work. But it's not that it doesn't work, they just don't understand. I don't want to just say it's all about knowledge, but knowledge is the underpinning. Because I think the logical process is, I don't need to take a treatment that doesn't work. But once that understanding is there, it's then possible to work on other barriers that are getting in the way. There might be parenting, there might be work, there might be just that you don't have time, but knowing how the treatment works and knowing that in the long term it's going to be worse for you. This means patients are more likely to come back. They need to get scripts. People will drop treatments. They don't come back for a long time. And we've all come across patients who are just going on their blue, they're managing on their blue reliever because they can get it over the counter. We've even seen that in one of our severe asthma patients in interviews who had a phase of doing that.
But it's really interesting because, we take the longitudinal view in a lot of diseases. I mean, why do we treat hypertension? Not for the blood pressure numbers now, it's for the long haul. Why do we treat diabetes? It's for the long haul. Why do we flick the switch when it comes to asthma and sort of, if it's wheezing, we treat it, and both the patient and sometimes the medical profession think, oh, well, they're not wheezing, so everything's A-OK, but clearly it's not. Yeah. Any hints, or shall we go on to the new and the fantastic?
So the other thing I just mentioned is the importance of actually asking patients whether cost of medications is an issue for them. So this is something that is relatively hidden to health professionals unless you ask, but it's very apparent to pharmacists that, at the cash register, the patient will say, oh, look, I'll just take the Ventolin today, thank you, I'll leave the other one. So we do know that it is extremely common for Australian patients, despite our wonderful subsidised medication system, for cost to be a barrier to adherence, and that's across the board.
Now I'm going to do that wonderful middle-aged man thing and say, look, I've read recently somewhere written by someone an article about, it was you, wasn't it? And it was in the NPS?
In the Australian Prescriber.
Yeah, can you just share about that fact? I was horrified at the variation in cost to give someone a low-dose inhaled corticosteroid is much better buying than combo therapy over time. So just give us the reference, and people, if they're interested, can look it up at the NPS website.
So the basic message here is that many patients in Australia are prescribed a combination therapy, and that actually has a higher cost to the patient, quite a substantially higher cost to the patient than just a low-dose inhaled corticosteroid alone. And the article in the April Australian Prescriber has a table that tells you how much each will cost the patient. So particularly if you've got adherence issues and it turns out that cost is one of those contributing factors, then you might need to trade off. Well, at least if you could get some of the low-dose inhaled corticosteroid, that will improve your symptoms and reduce your risk of flare-ups. So yes, I'd suggest you have a look at that table for some practical advice.
Now, new is always not better, but the biologic agents are coming, and for some patients they make an extraordinary difference. So I'm going to ask poll question number 2. Who in the audience has got a patient on an asthma biologic agent? So Xolair is the one that's been around for the longest. There's other ones. Nucala
has also been available for about 15 months in Australia on the PBS.
There are barriers, and our involvement is something we will talk about that in a moment. So, Helen, over to you. Currently available biologics for... Biologic, what a terrible word. It's a mAb, isn't it? It's a mAb.
Yeah, so there are 2 biologics available in Australia at the moment for severe asthma, and there'll be more available soon. These are extremely expensive medications. They cost the government around about $20,000 a year per patient, And so it's extremely important as good custodians of our health system that we actually only prescribe those for patients who truly are refractory to conventional treatment. I did a calculation that you could treat 263 patients for a year with low-dose inhaled corticosteroids for the same cost to government as one patient on a biologic. So very important to identify the patients that would benefit and that need this sort of therapy. So these two biologics are only available under PBS subsidy for prescription by specialists, respiratory physicians, allergists, immunologists, or general physicians that have expertise in severe asthma and who are based at a hospital, a public or a private hospital. And there's a pretty long application form. One of the key things for GPs to know is that in order for patients to qualify for these biologics, they need to have been seeing the same physician, the same specialist, for 12 months. Now, we know that that is going to change in a few months' time to 6 months, but it's still quite a long time. So if you have a patient where you've done some of these basics we've been talking about and the patient's asthma is still uncontrolled, that's a really good time to try and refer them so that the waiting time to get on a biologic is minimised. So just to talk briefly about the two biologics that are available in Australia. So we have omalizumab. Its brand name is Xolair, spelt with an X. And this is anti-immunoglobulin E, and it's approved for patients with severe allergic asthma. So there are very specific criteria that need to be met by this, from the specialist assessment before the patient can qualify. Omalizumab Xolair is prescribed, the dose is based on weight and IgE level, and it's given either 2-weekly or 4-weekly. It's subcutaneous injection, and the dose and therefore the frequency of administration depends on the patient's weight and IgE. So the second one is mepolizumab, also its brand name is Nucala, and this is anti-interleukin 5. So this is for patients who have severe eosinophilic asthma. So that's asthma that's eosinophilic despite taking high-dose combination therapy. Mild asthma is very often eosinophilic, but we're talking now about patients whose blood eosinophils are still elevated despite taking high-dose therapy. So mepolizumab, Nucala, is also given by subcutaneous injection. Unlike omalizumab, it's in a vial that needs to be made up rather than a pre-filled syringe at the moment. It's given as a standard dose, for the same dose for each patient, and once a month. So the frequency may be less. Now, for both of these medications, once the patient has been approved for therapy by the PBS, they have the first 3 doses given at the hospital, and they're observed after that in case of allergic reactions, for example. And then after that, very much we're trying to have the medication given on an ongoing basis in primary care as much as possible for reducing the burden of treatment for patients. So the key thing about both of these is that where they absolutely excel is in reducing flare-ups or attacks. They do also, in many patients, reduce symptoms, but the absolutely standout benefit is in reducing flare-ups and therefore the need for oral corticosteroids. And oral corticosteroids are a really major part of the burden of severe asthma because of their really profound side effects. So that's a summary of what we have at the moment. There are more in the pipeline, particularly for eosinophilic severe asthma.
80% of our audience don't have anyone on a biologic. So about 1 in 5 of the audience have someone who's on a biologic agent. And Leslie, this is going to leach out into general practice and we're going to be asked to do more.
Yes.
How do you see that coming over the next little while? So at the moment, it's relatively uncommon. It will become very common.
It's sort of fairly uncommon down on the south coast, but I know throughout Prince Alfred they have a very stringent 3 and then go to GP, 3 in the hospital and 3 to GP, which is really good. I think at the moment the nurses are a resource in either hospitals to the GPs, especially the ones that are taking these patients, and to actually enable GPs to have confidence, and as long as they've got an anaphylaxis kit, it's very uncommon for patients to have an allergic reaction to Xolair, which is really good. The outcomes for patients that are, it's supposed to be a third do really well, a third benefit, and a third don't do so well. Fortunately, we've found with our patients, as long as the patient's criteria is very strictly adhered to, they often do very well or moderately well, so that they get a reduction at least in their oral steroids and their flare-ups. But the beautiful thing that I love to see over the time, I've had some patients on it for 3 or 4 years, is the quality of life. We do a 32-question quality of life questionnaire at the beginning and after a year, and that's one of the things that I like to measure, is their exercise tolerance improvement over time. And you hear some fabulous stories for people that were just so bogged down in their asthma. That was their life, and it was just very difficult, like Helen was saying and Juliet was saying, that they really did not have a life that they could enjoy because they were always anxious about their asthma, always having blue puffers everywhere. I've got one patient now that's actually swimming 30 laps again prior to his demise with asthma. Oh. So there's some wonderful stories with the biologics, and I've got another girl that is doing really well on mepolizumab, but we only have 2 patients on that. So my role really is just to streamline the whole procedure of the patients coming in to see the specialist, working with the specialist, and it's great to work as a team. And if we need to follow up on any other comorbidities, well, we can easily refer them off for things that they need as well to help with their quality of life, like psychologists and ENT people as well.
So I'm sitting in my surgery, seeing this person who's got quite severe disease in front of me. What would make me think I should get these off to see Dr. Riddell ASAP, so the 12-month or 6-month clock is ticking? What 1 or 2 things should trigger that reaction in me?
Okay, so absolutely, if this is a person who's on maintenance oral corticosteroids for their asthma, they should go straight away as soon as you identify that patient. Patients who've had 2 or more courses of oral corticosteroids in the last year, that's a group of patients. I still think that it's good to try and do the basics, inhaler technique and adherence, do some work on that in primary care. It's incredibly valuable for you and the patient to be able to solve problems like that. But if you've done those basics, and particularly if the patient if you're not certain about what might be contributing to the severity of their asthma, some other red flags, patients who've got nasal polyps, that's very often the severe type of asthma that does need biologic therapy. That's one of the things we've identified. So patients who are smokers as well as asthma, they may not necessarily need a biologic therapy, but their asthma is generally more severe, needs higher doses than non-smokers. So those are a few of the things that I would look for.
That's interesting. We've got a question from Andrew here. What's the place of Montelukast? You talked about nasal polyps. That always makes me think Montelukast.
Yes.
What's the place of Montelukast in all of this?
Montelukast has a very limited role in severe or difficult to treat asthma. There are a few phenotypes of asthma that appear to have a greater response to add-on Montelukast. So this is in addition to the inhaled corticosteroid combination therapy. And the patients in whom we think that may be more effective are those who have aspirin-exacerbated airways disease, so patients who have reactions where their asthma is much worse if they take a medication like aspirin or Nurofen. Patients with nasal polyps will sometimes do better with add-on Montelukast. It may be something that will be tried at the specialist level while that clock is ticking to qualify for a biologic. But in general, the reduction in flare-ups is relatively small with it.
Okay. Another question while we're on questions. There are some studies that support that supplements such as the vitamins D, E, C, zinc, magnesium and flavonoids may have an important role. Any comment?
Yeah, so there's a large number of observational studies that show an association between low vitamin D levels and either a greater chance of having asthma or more severe asthma. But the evidence that adding vitamin D as a supplement changes asthma severity is conflicted. So there's no clear guidance. Of course, there are very good reasons why if someone is deficient in vitamin D, you would want to supplement that, particularly in a context where a patient may be at greater risk of osteoporosis because of their prednisone use.
Okay. Balancing patients' expectations, because if it's on sunrise or good morning, they think it's going to work for them. How do you juggle that?
That's challenging for any medication because we live in hope, don't we? And patients with severe asthma have such a burden on their quality of life, their family relationships, work, and that anything new sounds like it may be good. So we do have the specific criteria to qualify for the biologics, but I wouldn't underestimate the importance of, for a patient with difficult to treat asthma, of actually having a referral just to get a grease and oil change of everything, a new look at the whole problem from someone who probably has a lot longer than the GP has to spend on this patient. And you can often find modifiable factors. Even getting the patient exercising again, it makes a huge difference. So it can be valuable even if they don't qualify for a biologic.
Someone has asked that we go through the poll results as the first question again, because you subsequently gave some data from the Netherlands. So about 17% of people thought that 1% of their patients were difficult to treat asthma. 46% thought it was about 5%. And 29% thought it was about 15%. So the data from the Netherlands, which is very tightly, they like registers and tracking people through the system. They've got good systems like that. It's about 17% would be where we'd expect, about 17% of people. But if you attend to those three critically important issues, right medication, right dose, taken properly, and regularly addressing what's in it for the patient, why they should.
So those data suggest that maybe there's value in encouraging GPs to ask a few specific questions about symptom frequency, flare-ups in the last 12 months. So those data from the poll suggest it's maybe a little bit underestimated. And I just really emphasise the importance of asking a couple of basic questions. You know, are you waking up at night ever due to your asthma? How often are you using your reliever inhaler? How many canisters do you get in a year? So 3 canisters in a year or more is associated with an increased risk of flare-ups. So some basic questions that are very quick to ask.
And one of the issues that I confront is that people often stick on the prescription of their asthma medication at the end of a consultation for something else. So doing the reverse teaching that Juliet was talking about earlier, well, what are you taking this one for? You know, if they're not taking their inhaled corticosteroid because it doesn't work but gives them a sore mouth, you know, it's not a surprise they don't take it. So that knowledge build can happen there. We haven't got any other questions at the moment, so is there anything people want to add as we come towards the end?
Yeah, I was thinking actually about that. We had a question that was sent earlier about how we could improve the quality of life of people with asthma, which we hadn't really addressed too much. And I thought some of the qualitative work we had could really help us with that. I mean, when you're able and have time to ask about, say, the wider aspects of a person's life, a patient's life, say their work, their childcare, intimate and family relationships, and how asthma impacts on those, it's a question we would probably not very often ask. But this type of question will allow you to see if there are emotional support needs, if there are financial support needs or social support needs. And these are needs that patients in the interview said that were really not well covered. Often their emotional distress, so depression or anxiety, didn't come up because they said, I've never spoken about this to anyone before. So if we're able to ask about those questions, we can then actually support people in different ways. I mean, there is financial assistance for travel. There's asking about cost or understanding the cost of medications and asking if cost is an issue for patients. But as far as social support goes, people may have to give up work. And you may be seeing a patient who's lost a lot of cherished social interaction. So there may be opportunities to ask about what other social things they could do to replace work, because there are always possibilities, and often the solutions come from the patient. Although, again, I realise it takes time, but if there's opportunity to ask those things, listening is so important. Whether or not a patient is eligible for referral to a psychologist, if they're not, then an opportunity for them to talk with a nurse, for example, about the kind of things that are really concerning them can support someone so much if they didn't have anyone else to talk to. Yeah.
Leslie, there's a couple of questions here. Apparently you're supposed to scroll through a page on an iPad. I didn't know that, but now I know that. Okay. About how can nurses improve quality of life for patients? Can you very briefly talk about nurse-led asthma clinics and practices that you're aware of?
Okay, the first thing I like to do is, if they've come from a hospital admission or an ED presentation, is I like to ask them what led up to that. That gives me an idea of, and it gives them an idea that I'm interested in them and why this happened, and it gives me a lot of information as well, clinically. I also like to go through I don't do a HAD score. I do a very basic anxiety and depression score of my own, and I like to do an ACQ-5 as well. So they're little talking points, and that sort of gives me a bit of an idea and a quick lead into that patient. Sometimes we can't cover it a lot in that first assessment, but it will be something I'll highlight to go into more, especially if they're at risk with depression or anxiety. That's something that I will spend more time on. The quality of life is very subjective, and patients will find some things that wouldn't be of any interest to another patient. So it takes a little bit of time to get to know that patient. So the second visit, the trust is built usually because they're often feeling better if they're following the plans. And that's when you can get into more quality of life questions. How to help them is to find what you can sometimes do, I've found, is hobbies that can distract them from the anxiety of their disease, and I've had quite a lot of success with that. I had a patient that he used to bring in his peak flow charts. He did 4 times a day. Every day he had stacks. We bring it in, I put it over there, and I said, "What are your hobbies?" And he said, "Oh, I don't know." I said, "Well, you know, what do you like doing?" And it was photography and cars. So the next time I saw him, I got bird photos because he has these crazy cockatoos in his area. So I don't see that man except for the odd referral. He doesn't come into hospital. His anxiety with the team, with the GPs, he was helped with originally with some antidepressants and anti-anxiolytics, but he's found a life outside of his asthma, and he had a lot taken away from him. So that's what quality of life is, what the patient wants.
Yeah.
Good. There's a question here which is an interesting one. How long would a patient be on a biological before you knew that it was working for them?
The way that the PBS system is set up is that patients have 6 months as their initial period of therapy, and if they satisfy the criteria at the end of that from PBS, then they have another 6 months of therapy. With omalizumab, there's some fairly good evidence now from various studies that have been done that if by 3 or 4 months the patient hasn't responded, they're probably not going to respond. But the other thing is what the patient feels. So, you know, if by the end of 6 months neither you nor the patient really thinks that this has been worth it, then that's certainly time to stop, regardless of whether or not they would qualify for continuing. With mepolizumab, Nucala, our experience is that some patients actually feel better by the second dose, which is in a month after the first. That's not universal, but some patients certainly can feel the difference quite quickly. So, you know, 6 months, if the main problem is flare-ups, then 6 months is really needed to be able to see that. it's always good if the patient has actually symptomatically improved. It gives you a much better idea that they're a responder or not.
A question here from Steve, advice on resources. So do you want to talk about the CRE toolkit?
Yes. So one of the dilemmas we have with asthma is that percentage of patients with difficult to treat and severe asthma is actually quite small. So there's a lot of public messaging that's intended for patients who actually would do much better if they took their inhalers and took them correctly. So there's a lot of resources for that. And just in recent years, we've been developing more resources for those patients, for health professionals who are managing patients with severe or difficult to treat asthma. So one that was just launched about a month ago is from the NHMRC Centre of Research Excellence in Severe Asthma, and it's a toolkit. So if you type in toolkit and severe asthma, you will find it. And this has been developed with very much multidisciplinary input, and it has a whole lot of resources about how to diagnose, how to manage difficult to treat and severe asthma, and also a section on the personal experience of living with severe asthma with clips from patients who do have it. So that's one resource. There's the NPS program that's been running for GPs managing patients with severe asthma, and there'll be more resources coming out in the next year or so. Really practical resources are essential to help with this day-to-day management.
We should mention the Asthma Australia's consumer resource as well on severe asthma, which also came out at a really similar time if GPs want to refer patients to that information source.
Asthma Australia, asthma toolkit, a severe asthma toolkit, and National Asthma Council would be the big three acceptable resource.
So at the moment, the Australian guidelines tend to focus more on primary care management, but with the updates that are coming to that, we will be dealing more with the severe asthma part of the spectrum.
Another question, any thought of using MAB medications for severe uncontrolled allergic rhinitis?
Well, so patients who have nasal polyps as well as severe asthma do often find that they get a marked improvement in their nasal problems when they're on the biologic. Unfortunately, it's not approved for that indication. The one that I really find I would love to have is for severe eczema. So a patient who was telling me last week that he has to vacuum the bed each day because he's shedding so much skin. But you know, we have to work on, and unless we have exceedingly wealthy patients, we're limited to the conditions for which these medications are approved at present.
Okay, we've reached the end of our hour. So the take-home messages are: it's important to identify these patients. Things can be done, but you have to apply systems to it. There's advice, there's support. There are people to help, respiratory physicians, if they're available, have got access to the biologic agents. And consider early referral for severe, difficult to treat, or if you just need another look. You know, we sometimes get too familiar and overlook things. So I just have to thank our panel members, Helen, Juliet, Leslie, thank you for giving up your time for being here. NPS MedicineWise, the team. There's a lot of people standing out there waving at us, which is always fun, and most importantly, the audience.